Good afternoon, everyone. This is Karen Kennedy. I serve as Vice President of Quality and Patient Safety at the Indiana Hospital Association. Thank you for joining us this afternoon for this webinar. We're joined today by several of my colleagues here at the Hospital Association office. And then also we are joined by the Center for Patient Safety, who is our partner in this work that we're currently doing to improve care transitions. And in just a short time, Abby Garcia from the Office of Rural Health from the State Department of Health, she will be joining us in the IAJ office too. She's actually en route from an on-site visit that she had in the southeastern part of the state. So again, thank you and welcome for this Improving Care Transitions Among Multiple Care Providers in Rural Areas. As we often like to do at the Indiana Hospital Association in regards to our patient and safety work, we always like to start with our mission, which is to engage and inspire healthcare providers, create safe cultures, create reliable systems of care, and prevent patient harm in Indiana. And we do this under the key principle that we don't compete on patient safety. I think this is this work that we're doing with this care transitions, I think it's really ties in very nicely with our mission. So again, we appreciate everyone being on the call today. If we could have everyone, if you're on the computer, if you could chat in your name and organization, that would be very helpful, especially for Shelby Hornbeck, who is with us today, our patient safety intern, who will be taking attendance, and we'll kind of do that roll call at the end as well to make sure, kind of to see who is on with us today. Additionally, this is being recorded, so you'll have access to it after the webinar as well. So I'm going to turn it over to Tina Hilmes now from the Center for Patient Safety. I know she's going to be joined by several of her colleagues today. Thank you. Tina, are you on the line?
I am. Thank you, Karen.
Great.
So just a quick review. We are the Center for Patient Safety, and we are located in Columbia, Missouri. We are a federally designated PSO, and we have been around since 2005. Our mission is reducing preventable harm, and we do this through our values of integrity, culture of patient safety, excellence, and advocacy. Next slide, please. So today I will be joined by my partners, Alex Christian, who's our Executive Director, Kathy Wire, who is our expert on long-term care, and Lee Varner, who is our expert on EMS. And for today, what I plan on doing is a project review, and then we're going to go into a case example, kind of a story to help get you to identify what some of the problems are with transitions. Then we're going to go over communication and some of the special issues that long-term care faces. And then Lee will take over to discuss about some of the issues that EMS faces. And then Alex Christian will round up with communication and how culture plays into that, and how you can actually measure to find a starting point for improvement. And then I'll wrap up with a summary of everything we reviewed for this webinar. Next slide, please.
Tina, I'm having some trouble forwarding the slides, so bear with me. There you go.
All right. So this project on transitions of care through multiple institutions, it's to provide training and tools, not just for hospitals, but also for long-term care organizations and emergency medical services that will help support the transition of high-risk patients, especially those with chronic disease such as COPD and respiratory issues. We're finding that those types of patients are extremely medically fragile, and the more information that can be shared, the better. We hope to increase your knowledge of shared accountability and just culture. And then throughout the following months, the next month, we hope to develop and share communication tools and techniques that can be used amongst hospitals and long-term care and EMS. So if you could go on to the next slide, that'd be great. So some activities that we have coming up with this project is we are doing a problem identification webinar today. That's this webinar. Next month, what we're going to go into is kind of a deep dive into communication tools, communication techniques, and all of the components that are actually involved with successful communication. Then in January, we're going to take a week and we're going to have some in-person patient safety forums at 3 different locations. These are going to be 4-hour forums where it is some TED-style talks and then some engagement with your partners and getting to meet face-to-face and breakout sessions where we kind of focus in on the culture component of communication. And then ongoing as the month of November goes on and even into the early part of December is to identify those community members as potential partners if you haven't already. Thinking about skilled nursing facilities that you discharge to frequently, and then also inbound and outbound EMS agencies you interact with. I know we've had a couple of people just recently reach out to us for some help in identifying partners, and I will be responding to you probably today, later today after the webinar. So could you forward to the next slide, please? So the big theme for today that you're going to hear about is communication. As George Bernard Shaw once said, the single biggest problem in communication is the illusion that it has taken place. Think about your everyday conversations, not just with your coworkers, but also with your family, your spouse, your children. How many times, especially with children, have you asked them to do something or told them to do something, and you think that once you've told them or once you've asked them that your part is finished, but then when whatever it is you asked them to do, whether it was clean their room or go into town and run a quick errand, you find it wasn't done and you realize that there might have been something lacking in the communication. Maybe they didn't realize that it was an urgent errand that needed to be finished, or your child didn't realize that you wanted the house cleaned that particular afternoon. So there's a lot more that kind of goes into communication than what we actually think. Next slide, please. So I'll go ahead and start talking, but for concise communication, we are not only sending a message, but we should be including a process for feedback for verification of that message. Our communication should include the who, maybe that's our patient, the what is the issue that's affecting them, when, include when it started, the where did it start? Where are they? Are they in the nursing home? Was this an accident? Is it a scene? Why, if you know the why it's happening, if they are having respiratory issues, did they get a pneumonia? Do they have a cold? Do they have chronic diseases? The how, that might include the how you might be getting them to the hospital, and also the how much. That could be something like if they are on the medication, how much medication, if you're an EMS agency transporting, how much medication you may have given during the transportation. And so with those beginning concepts of what all is included with communication, I'd like to start in on our scenario. Next slide, please. Whoops, there we go, perfect. That one. So with our scenario, what I'd like you to do is think about yourself in the role of an ER physician who's coming to the end of his shift in the ER. As that ER doctor, you get a call from an associate in the community who oversees the local nursing home. He states, I'm sending you a 68-year-old male with a history of interstitial lung disease who has been having some shortness of breath. But at that time, before you can get any information on this potential patient, a nurse grabs you and says, we need you. There's a code. A patient just arrived without a pulse and without blood pressure. So you run to the room where she pulls you, and you see an elderly man who has no pulse, no blood pressure, and low oxygen saturation. The patient is coded and intubated, and a chest x-ray is taken. The patient regains blood pressure and a pulse, but still remains critically ill. And so you're trying to get more information on this gentleman to begin the diagnostic process and the admission process, but the EMS team has already left without speaking to you. Maybe they had to go out on another call, and they didn't leave any information. The only other information you have is an envelope that identifies the patient as a 68-year-old nursing home patient with a history of shortness of breath. The x-ray shows infiltrates in the lung, and based on the minimal information you have, the x-ray, the shortness of breath, the code, the low oxygen saturation, you make a presumed diagnosis of aspiration pneumonia with septic shock. It doesn't hit you until hours later that this 68-year-old nursing home man is the one that the local physician was calling about until hours later. So you begin antibiotics, fluids, and pressors, and you contact the ICU, and you give a brief report as you are being called to other urgent patients in the ED. Your patient is then moved to the ICU, but 3 hours later you find out, after having arrived in the ICU, the man codes again. He regains his pulse, but his blood pressure remains extremely low despite being on 3 different vasopressors. At this point, the ICU team reaches out to the nursing home physician to try and get some more information. And they discover, by talking with him, that the shortness of breath was also associated with chest pain and came on very acutely. The nursing home physician states that the patient had complained of feeling faint and like he was going to die. With the increased information, your diagnosis of aspiration pneumonia and septic shock is changed to suspecting maybe a pulmonary embolism. And finally, 5 hours after the patient has arrived at the hospital, thrombolytics are started. The patient begins to respond to these thrombolytics, and eventually he's transferred out of the ICU to the floor, and then recovers even more and is transferred back home to the nursing home. So next slide, please. So as you can see with the story, there's a lot of transitions there. And this type of transition of a patient coming from a nursing home and ending up at the hospital, throughout the country, these are things that happen on a daily basis. Maybe not those specific details, but transfers out of nursing homes to the hospital. So let's really stop and think of every single handoff that happened where gaps in communication can occur, and it can be just dropped information or misinformation or even just missed. So our story starts with the nursing home where the patient becomes ill, and the information from the nursing home needs to be shared not only with EMS who is picking up the patient, but they also need to give that information to the hospital so the hospital knows that the patient is coming. Then the patient arrives at the emergency department, and EMS needs to hand off information there. So between starting at the nursing home and going to the emergency department, already you're looking at 3 intersections right there. So then, once the emergency room has stabilized the patient, they have to transfer up to the ICU, which is another opportunity for missing out or dropping information. Once the patient is stabilized and is coming out of the ICU and going to the floor, there's a 5th intersection there where information could be dropped or missed. And then as the patient is ready to leave the hospital then not only needs to call and give report to the nursing home, to update them on any changes that went on with their patient, but then they also need to give that same information to EMS folk who will be picking up the patient and transferring them so that they know the background of the patient should anything happen during that transport back to the nursing home. So that's about 7 intersections of the patient within the whole healthcare system where information could be missed, it could be dropped, it could be misinterpreted. And so those are areas where you need to be giving information but also providing that channel for feedback. And so with that, let's start with the challenges that long-term care may face with their information. And so with that, I'd like to hand it over to Kathy Wire, who is our long-term care specialist. Next slide, please.
Yeah, one of the goals of this project is to let each of the various provider groups develop a better understanding and appreciation for the others and the nature of the work that they do, but also the constraints that are built into the nature of the work that they do. So I'm going to talk a little bit here about post-acute and long-term care and what it does and why that presents challenges in situations like this where residents are moving back and forth. The biggest one, I think, is just a conceptual one that over the last 5 or 10 years with the culture change movement, long-term care facilities have moved very much from a medical service model to a residential and home-based model for their residents. So that means that while they still have to provide for care of chronic and underlying conditions, the effort has been very intense to try and make this a more home-like and less intrusive experience for them. And in fact, Medicare, which, and I realize this is kind of a reimbursement-based definition, describes long-term care as a range of services and support for personal care needs, and that most of it isn't medical care. So we have folks living in an environment receiving care and support for their chronic and long-term needs, while at the same time focusing on things like mobility, nutrition, and other assessments and status points that typically are not part of long-term care documentation. And where there has been a focus on more intense medical care, it's actually been on keeping residents out of the hospital. In other words, how can we provide more care in the long-term care facility? And so all of that affects this situation. So, you know, long-term care is providing care that's documented certain ways, it's staffed certain ways. And so when you superimpose a medical emergency like this, sometimes it makes it difficult for long-term care to just jump in and immediately provide everything that the next caregivers need, but obviously that's a problem. So let's move on and drill down a little bit on what that means in some various components. As I mentioned, long-term care deals more with chronic conditions versus emergent ones. Usually if you're dealing with a hospital transfer, you have an emergent situation. And I would contrast that with the transfer back to long-term care from the hospital, where the communication needs really are kind of different. We don't want to ignore that. That's going to be part of this project. It's just not part of the scenario that we're talking about today. So look at how long-term care is built. The documentation revolves around daily things like food, toileting, medications, therapy. There are weekly and monthly assessments of some things, and charting supports that, and this is all part of that long-term view. For example, you don't have residents on monitors that are keeping track regularly of their heart rate, pulse oximetry, and all of that. So when a situation evolves, it's a challenge to jump in and suddenly do that real-time measurement. And as I mentioned, much of the focus and research and development over the last few years, which is a good thing, is how can long-term care facilities help to keep their residents out of the hospital, recognizing that in many situations they're better off in their home than they are in a hospital setting. Which leads us to the next slide. And the nature of long-term care documentation and communication, which relates to all that. So the charting is really developed to show, for the most part, long-term situations. You look for trending. You look for things that are developing that might reflect a change in those underlying conditions. And we all know that folks that are in nursing homes do have acute situations, and so we have to address those. But when we look at communication and documentation in other settings, you know, there are some realities about long-term care that are just out there. There may or may not be a registered nurse on site. Frequently, smaller rural nursing homes are staffed by LPNs at night. That's not a bad thing, in that you have some limitations on the ability to communicate in real time on site. Your physicians are off site, and in this case, I think we have that as part of the scenario, in that the facility undoubtedly got hold of the physician is making a phone call, but the folks that are at the nursing home may or may not be aware of the fact that communication was interrupted. And so you may also have a situation where the staff at the bedside of the resident may not even know what the physician is thinking or doing as they move forward. So how can they support that in the best way with their communication to both EMS and the hospital? And these are just kind of structural inherent challenges that we want to start talking about and moving toward solving as we work through this process. How do we communicate effectively to EMS and the hospital in light of these constraints? Next slide. So a lot of long-term care folks that I've worked with have a form that they fill out when they send a resident to the hospital. This particular example is from Missouri, where we had a multidisciplinary task force that developed some very extensive forms for long-term care handoff to the emergency department. And I kind of looked at this one and went, really? You know, in an emergent setting, some of these things are important. Some of them are things that you might want to fax after you've got the resident off in the ambulance. So I think we need to look at our standardized processes that we're doing, and perhaps move towards scripting those emergency conversations and communications. One of the things we work with in patient safety a lot is the concept of redundancy. And so in this case, I think, you know, we had a really good effort by the physician to try and communicate directly to the emergency department what his concerns were. Unfortunately, that communication was truncated and he was not able to complete that before the patient showed up, and they began treating him based on incomplete information. So one of the things we always look at is redundancy, and how can perhaps the nursing home staff back up that communication, either with what they tell the emergency medical crew, or perhaps by faxing information to the hospital. Those are just suggestions, and again, those are the kinds of issues that we want to focus on as we move forward in this project. Next slide. As Tina alluded to, we have a two-step problem here, because you're communicating from, in the initial transfer from the nursing home, you're communicating with two different sets of providers. You want to make sure that the EMS providers have what they need to know in order to provide safe transport and support of that resident, now patient, as they move them to the hospital. But then you also need to be able to communicate with the hospital. Unfortunately, what I see a lot is folks put together a packet of information, they hand it to the EMTs who don't really have a chance to look at it. They pass it off to the hospital and may or may not include a report on any new developments that happened as they took care of the patient. And again, this is what we really want to focus on. But I think as the nursing home providers getting this person ready to move, that's one of the things we need to think about, is that we're dealing with two different kinds of providers with two different sets of needs. and that EMS really is not in a position to just carry our water in terms of communicating information. What do they need now? What does the hospital need now? And what is the most effective way of getting it there? And that gets us to the next slide. So, excuse me, you know, we have barriers. And one of the things we want to look at is what are the barriers that the various providers in these settings have, and how can we as a group work collaboratively to try and overcome those. So in this situation, I think throughout, one of the things we need to think about is how do we meet the needs of the next providers, not our needs, not what we've done to meet our own expectations or policies, but how do we meet the needs of the next providers? And especially in rural settings, how do we overcome location issues? Because, you know, in the example, which I don't know if it was rural or not, but you may or may not have the DON in the building. She's trying to manage what's going on. You have a physician who's off site, and with everybody in different locations, how do we deal with that? So that leads us to the next concept, which is figuratively, literally, virtually, how do we bring people together to help them process information most effectively? What pathways can we work out? And that gets us to Lee's going to talk about silos and how we develop silos and what we can do about those.
Thanks, Kathy. Hello, everyone. My name is Lee Varner, and it is my pleasure to be here with you today. And I'm going to be talking about transitions of care and communications from an EMS perspective. And I like this visual here because it does help us realize that there are many silos in healthcare, and that it's easy to become insulated into your silo, not really or fully understanding what other people's expectations and needs are when it comes to accepting that patient when we make the handoff. And so this conversation that we're having today and this project that we're working on, I'm thrilled about, because we've been working with EMS for the past year around communications and transitions of care. In fact, we've been out speaking on the topic at several national conferences, and I usually ask people to raise their hands in these presentations we do and ask them, you know, are you having problems communicating and working with other healthcare providers in your community? And almost all the hands go up. And then I ask everyone to, lower their hands if they're working on a solution, or if they found a way to work more closely to mitigate or improve communications in the transitions of care. And most of the people just keep their hands up, meaning that they're still having problems around communications and this issue of working with other healthcare providers. And so over the next couple of minutes, we're going to talk about this. I'm going to share with you some early preliminary data that we're gathering around this topic, as well as I'll reference a couple of studies in EMS that's looked at transitions of care and communications, because I think there's some universal ideas and concepts we can pull out of there that will help us in this project. So if you move to the next slide, that would lead us to looking at some of this data. And so what you see here is a survey that we developed with the National Registry of EMTs roughly 3 years ago. The survey is similar to the SOPS survey, the Survey of Patient Safety, but it is geared for EMS. So it mirrors a SOPS survey. It's not the same survey, but it's one that's been developed to understand safety culture in EMS. And what you're specifically looking at are the 3 lowest scoring areas of the survey and the preliminary data that we've been gathering from across the country. And so the lowest scoring area points out that information exchange and working with other healthcare providers and exchanging that information is an issue. That's what our EMTs and paramedics are telling us. And so I think we have a great opportunity here with this project to look at some ways to improve and pilot some improvement concepts and processes as this project unfolds. Would you go to the next slide, please? So a few years ago, a study was released. This is a qualitative study that looked at communications in EMS. And actually, this topic has been fairly well researched, primarily in the EMS to hospital setting. But I think there are some universal takeaways that we can draw out of this and another study we'll talk about here in a minute. And that's, what are the expectations when we're working with other healthcare professionals? What is it that other people need when it comes to the patient handoff and communications? And this was really one of the key takeaways from this study, that there wasn't active listening taking place between different providers. And a lot of that was set around the working relationships, that interdisciplinary understanding of what does that other provider do, what type of information do they need, and how can I best share that with them? And I think Kathy pointed out that, we can develop some really complicated or complex types of transfer documents, but if we become too perspective in developing those, we can paint ourselves into a corner or put ourselves really into one of those silos where no one's going to use it, and it could lead to even more confusion. So I think the best way to really approach this is the way we're doing it now, and that's at a smaller level, at a community or regional level, and understanding, what is it that other provider needs, and taking the time to sit down with them and getting to know who they are, what they do, and how can we best share information. So that's whether if we're handing a patient off from a long-term care facility to EMS, or EMS working with a hospital, or taking a patient back to long-term care. How can we best work together and learn from one another, but also develop that relationship so those expectations are being met? Next slide, please. So this particular study that was done primarily looked at the handoff between EMS and hospitals. And I think what we can draw out of this study is that oftentimes there's a short period of time that we have the other person's attention. And in this study, they talked about paramedics or EMTs having the golden minute, that when they walk into an emergency department, they might only have 1 minute of the nurse or physician's time to really build the case for their patient. Even though they've called ahead and let them know that they're going to be coming and they're going to be arriving, that everybody's busy. And again, we're oftentimes in these silos where we're not hearing what the other person is saying. So how can we break down this 1 minute so that we are following more of a standardized approach, and one that we know we're delivering information in a way that it's going to be received or expected by that other provider? Can you move to the next slide, please? So some of the communication barriers we've talked about already. And one of those that we really haven't dug into is that interdisciplinary strain, because we all want the best thing for our patients. And we work with our patients every day. We're busy professionals, but really not, one of the challenges is not spending enough time understanding how we can work more closely together, but instead expecting what we're doing on our own is going to fit into the mold of that next provider. And so really this work comes down to having the leadership of the organization set aside the time to make this a priority. So we will be working with other healthcare providers in our community, and we will be taking the time to sit down with them and understand what their needs are and how they want the information, or how we can best work together. So we're not put into a situation where we are rushing through something, or we're not getting all the details and we can't pass it on to the next provider. Next slide, please. And so if we wanted to tie this all together, I think a great bow that we could wrap around it would be how we look at this as being part of a important safety culture initiative, as well as a safety culture perspective. Now, about 5 years ago, a report came out that was written by EMS leaders called the National EMS Culture of Safety. And it talked about a number of things that we're presenting and discussing today in this webinar, and that really we need to adopt a greater way to look at our internal culture of our organization, and realize that that culture is driven by our leadership, and not expecting our providers to go out and be making these changes to improve these processes, but realizing it from a cultural perspective that leadership needs to own this, but also from a process perspective as well. So I'm going to pass it over now to Alex Christian, who's going to talk a little bit more about the cultural perspective and things that you can do to improve that within your organization.
Thank you, Lee. Hi, everyone. Good afternoon. It's a pleasure to be with you today. I think between what Tina, Lee, and Kathy talked about so far, really it's digging into each of our respective areas to really determine what's going on with communication, what are causing the issues. We've talked a little bit about that already, but what now is it's time to dig in and get a little bit more of the causal factors associated with those communication barriers that we have. We know in the past that healthcare has been punitive. We know that that's still occurring in a lot of organizations, that individuals are getting fired if they speak up about making a mistake or maybe forgetting to communicate information that should have gone to the provider that they're handing off their patient to. And those are concerns. Those are things that need to be addressed, and there is a way to do that. So I'm going to talk a little bit about the safety culture assessments that exist. Lee mentioned already that there is one for EMS, and there is one for long-term care or nursing homes, and there is one for hospitals. In the hospital industry, this has been done for quite some time. We've been using these surveys to assess employee perceptions, to determine if they are afraid to speak up if they make a mistake. They have used this as a diagnostic tool to really determine what are the key areas or opportunities that we have to address within culture that will allow us to make changes to those to mitigate future occurrences. So how can we start to improve that culture now? Because culture can take a long time to change too. So if we go ahead and go to the next slide, this is just a couple of comics that we have here on the next couple of pages that really, are kind of a humorous way to look at the problems that we know exist. We need to be looking to reduce those assumptions that just because it happened, that's okay. Let's go to the next slide. We need to address the fact that we're not talking about these things, that we're, instead of trying to go ahead and address the problem, we're just going to wait and hope that things improve, and it's time to start these changes. And this project is intended to do that. Let's go to the next slide. So the ability to embed patient safety, it's not an easy thing, but it's something that we have to continue to work on every day. You've heard the statement that culture eats strategy for breakfast, and that's true. You've got to monitor it every day, but it's something that can be embedded into the organization. So when we look at it, we're looking at ways to prevent errors, to learn from the errors that do occur, which means that we need to encourage our staff to speak up, right? We need to hear from employees what their issues and concerns are. And we do that by really building on this culture of safety, that everything that we do really revolves around the safety of our patients and our providers. Next slide. So we talked a lot about communication and how that can impact care, but let's also look at patient safety culture. So we know, again, that in the past, culture has been punitive. And when we start to look at patient safety culture, the way that that's impacted is because if shortcuts are tolerated, then that becomes the common occurrence. That becomes what employees will do on a regular basis. You can basically summarize it as saying that culture is what your employee will do when the boss isn't around, right? Are they going to all stand around a water cooler, or is there an expectation that work is still getting done? There's also the idea that, again, we've talked about this already, that if leadership doesn't make it a priority, then no one will. So we do need to make sure that leadership is on board. And one of the webinars that will be coming up in this project is around leadership and how to address that. Next slide. So we talked about this way to really analyze and assess what your culture is like currently. And again, hospitals have been doing this for quite some time. There have been surveys around, tools around to do that. And there are tools available for nursing homes as Lee said, for about 3 years now, and in development, there's now one for EMS. And when we look at who, what, how, when, where, all of those things come into kind of your own evaluation and your own interpretation of who you want to assess, what tool you want to use, how you're going to assess, distribute the survey to them. Do you want to do that through electronic means or paper surveys? And there's a lot of different ways that people would suggest that that's done. The Center for Patient Safety has been doing these surveys for about 8 years, and we know that there's certainly some best practices around distributing surveys to staff. I'm sure that many of you are probably familiar with employee engagement surveys. We get a survey link on every receipt that's given to us, right? So we know that surveys can be valuable to help measure and determine where you are currently in your culture journey. But really determining how to administer the survey can be just as important, so that we make sure that those that the data points that we're analyzing afterwards are valid. We want that information to be reliable and dependable. So if you are a hospital and you've assessed your culture, then the Center for Patient Safety can actually help interpret your results for you and look for some of those causal factors. If you are an EMS, we can administer that survey for you. That's included under this project. And if you're a nursing home, if you'd like to assess your culture and you haven't yet, you can do that. Let's go to the next slide. When we look at analyzing the data, that can be just, as I said, that can be just as important. So we want to make sure that you understand the data that you're looking at. So with the assessment, we'll provide your data back to you in a format that really gives you your top scoring areas, your opportunities for improvement, and then really gives you and guides you on those next steps. But what we want to be able to do is look at your regional group and let's see where all of your organizations align together. We can compare to one another. We can compare and benchmark to other organizations like yours. And let's go ahead and go to the next slide. And that gives us that ability then to take those next steps to really plan and set some goals for the initiatives under the project. And I think we have some incredible opportunities. As Kathy said, we really need to address the constraints that you may find yourself in and make sure that we're adapting and adopting those to the constraints that your regional group is experiencing also. And if we can collaboratively meet those needs, then that's going to provide better care for our patients and safer outcomes. So also, as Lee said, we really need to use this opportunity to learn from one another. So if we can gather some measurements, some benchmarks, and comparisons to see where we are, we can use those in the patient safety forums that Tina mentioned in January. We can use some of that data to really look deeper at where each of our organizations is, and again, how we can build these programs to address these barriers that each of our groups is having, and set some expectations for one another and hold each other accountable as well. Next slide. So with that, I'm going to go ahead and turn it back over to Tina.
Thank you, Alex. So as you can hear or see from listening to all the different areas, we're really talking about communication, and not just within our own little silos, as Lee pointed out, but really kind of opening our eyes and getting outside of the woods that we are in and trying to look at communication from the perspective of long-term care facilities or communication from the perspective of EMS agencies. And with communication, it all starts with culture, as Alex mentioned. What will your staff do when the boss isn't around? And utilizing tools to kind of measure where your starting point is. Once you have really some definite data to find out where your weaknesses are and where your strengths are, you can start using some of those strengths to work on your weaknesses. And once you know that, then you have to have leadership there. Leadership has to be stepping in and really setting the goals and role modeling the type of behavior that staff should be doing when the boss isn't around. And so leadership is extremely important, and that is a component that we will be going into later in this project. And then also teamwork is so important. Everyone has a role in looking at communication and in helping our patients. And so understanding how teamwork works and how you work together as a team, not just within the hospital, but also outside hospital walls. I think historically we've really have been looking at trying to improve the communication and teamwork within hospital walls, and we have been trying to, as hospitals, work on that discharge component. But I think what was always lacking was the bringing in of those other areas of healthcare to really open up our eyes to see what types of things they need in the discharge process and what those other areas of healthcare need as the patient moves in throughout the healthcare system. So what we really want to look upon is communication and teamwork, not just in hospital walls, but that communication with EMS and long-term care and teamwork with each other, and really trying to break down those silos and break down those walls. So next slide. And with that, I think I'd like to open it up for any questions that anyone might have.
We have opened up all the lines, so if you'd like to either ask your question verbally, or if you want to chat in your question, that's fine too. And if you're not speaking, if you could put your phone on mute, that would be great as well.
So how do you get, this is Tina from Avalon, how do you get, I know you guys were talking about the surveys, but I do have one community
I will try to not bother you.
And I do stop at the EMS all the time and talk to them and communicate with them, but how can I?
She only sent it to you. She didn't send it to anybody.
Can we just hold 1 second? We're trying to actually mute the line that's speaking.
Yeah. No, I mean, I verified her Medicare before she came in, and I put it in her folder. And that's all I could do because I didn't have anything else. Right. I don't know why it's been.
Excuse me, someone is on not on mute and is speaking.
You just want us to put her do the chat online, or?
Actually, we can hear now.
Okay. I said I have a community. I'm from Avalon and Ligonier here, and I have a community that I'm trying to work with and get with the hospital and work out more ways that we can work together. Is there like that survey you were talking about? Is it an online survey that we can do so we can find out, you know, where we need to step it up, where we need to work with different things? I do stop with the EMS quite a bit in that community to talk with them and go over things and things that can change. So I feel like we have a great communication with the EMS, but I'd like to up our communication with the hospital as well.
So this is Alex. It sounds like maybe you might be interested in the EMS culture survey. Is that correct?
Yeah, I'd like the survey, that we could do a survey so that we could figure out where we need to step our means up to where we can communicate with the hospital a little bit better than what we do. I do stop into the hospital as well. They are a small hospital, and you know, it's hard to get with their planners that they have there, the discharge planners.
Sure, absolutely. So like I said, the survey, we're doing that through the project. So that, I think Tina, when she sends out an email, that may include some of that additional project detail. And so that should tell you then how you can express interest in doing these surveys. And for those, if you are within a hospital and interested in getting at least the feedback reports that can align with some of these other provider groups too, we're working with Indiana to make sure that we can get some of that data if you so choose, and then we can build that into those reports.
we would definitely want to do both. We just need to see where we can actually where what's going wrong, so we can actually build on that. I mean, whether, regardless if it's negative feedback or great feedback. I mean, we just did some surveys and got some great feedback. So we just want to build upon that.
Hi, this is Tina, and you can actually, I believe my email will be on one of the slides coming up, one of the end slides with contact information. And if you want to even just email me and let me know, you know, what you would like, we can actually get that set up for you. And it is an online survey tool that people can take. And so since it is being done through a third-party vendor, then it really helps to keep it, you know, anonymous. And so everyone really kind of likes being able to see the feedback. And it does really help highlight what your strengths are and what your weaknesses are. And it really gives your organization that starting point.
Yeah, that's where we would like to start with something like that. Now, I do have your pictures up here, and it tells who you are, where you're from, but it does not have any email addresses.
I think if we go one more slide forward, I think it has, or maybe even two more. There we go. There's my email right there.
Thank you so much.
You're welcome.
And just want to make sure, is that Tina that's speaking?
Yeah, it's
Adam?
Tina.
Okay, we'll make sure we've written that down, and we'll make sure that we get that information.
Okay.
Okay. So, and I see a comment here about the standard form providing pass-off info from long-term care to EMS to hospital would work well. We are actually going to try and bring in, and I think we might try and do this in the patient safety forums, some multiple different forms to kind of look at, because while there have been some forms developed, you know, one generic form doesn't always work for everybody. So part of our goal was to kind of bring in multiple different forms to maybe sit down with people face to face and look at different forms and kind of give you the opportunity with your partners to look at what component of what form might work for you, and maybe help design a handoff tool that would really work well for your community. So I don't know if that was a question, but I just wanted to highlight that.
I have to check more into it to see what form that they do use. I do know that they do have a form that they do use, but I'm not sure which one it is.
All righty. Are there any other questions?
And Tina, I think that ties in very nicely to a question I've received is the opportunity to maybe share the participants could bring in or send in their forms that they're using already, maybe in advance. So I think that ties in nicely with that request to see what others are doing. And then we did have okay. Yeah, and I think the other question that we received is the case study that you had early on in the presentation. Is that written up, and is that something that could be shared if it is written?
This is Kathy, and actually we took that from, we can send it out or a link for it. It was written up for the AHRQ Web M&M publication series. It's an online thing that they do where they take a scenario and then have expert commentary on it. So we'd be happy to share that link.
That would be wonderful. Thank you. Any other questions or comments? I might ask one more time that if you have not chatted in your name and organization, if you could do so, that would be wonderful, because we are collecting attendance. Or if you're not on the computer and you want to go ahead and just verbally say that would be great as well.
Harvey LaGrange is on the line.
Thank you. I think, and also just wanted to say too that as you are, going through this process between now and May, I think please just be upfront if there's something that's not meeting your need, or if you have a special, unique challenge. Please let either Tina or Kathy or myself, and again, this is Karen Kennedy at the Indiana Hospital Association, let us know, because I think what's very unique about the Center for Patient Safety is that they pull together on their team with immediate access to someone who has that experience with the EMS, long-term care, and the hospital. I think that they are more than willing to get on a phone call. There will be some in-person opportunities as well. So I think it's, I think they're not an organization, and as well as Indiana Hospital Association is not, as well as the Indiana State Department of Health. We don't want to make this, one-size-fits-all solution. So if you have anything unique to your organization, please let us know, and let's have that conversation offline. Or feel free to share it here and ask the question. That's partly what, if you're having a barrier, probably others that are involved in the project are having the same problem. No more, I don't have any more questions in the chat. I think we will go ahead and just wrap up just a few minutes early. And really, I thank everyone for your time. And we will be following up with an email with a link to some of those resources that we discussed, as well as the PowerPoint and the audio recording, if you want to share that with others within your organization. Just before we hang up, Abby, is there anything you'd like to say?
This is Abby Garcia with the State Office of Rural Health, and this is just a really good opportunity, I think, for everybody to break down those communication barriers and look at how to connect with the resources in your community so that we can improve patient safety and patient care. And I think that's the goal of all the projects that we're doing through SHIP right now, and it's just really exciting to see all of these resources available. So please reach out to me also if you have questions or concerns. If you haven't filled out the SHIP feedback survey, please do. Today's the last day. That will close at the end of the day. If you need a link, let one of us know. And other than that, thank you so much.
Thank you.
Thank you, everyone. That concludes our webinar for today.